Hello, and welcome to Global Scalpels, a podcast dedicated to the 5 billion people worldwide who lack access to safe and affordable surgery.
I'm Rihanna.
And I'm Taylor.
And together we're Global Scalpels. Today's guest is an honorary research fellow in the Value-Based Healthcare Programme at the University of Oxford. He has first-hand experience working with different healthcare systems in both Europe and the Middle East to help healthcare systems focus on value-based healthcare. He's passionate about understanding how we can improve population health by addressing social determinants of health. Without further ado, I'm excited to introduce today's guest, Dr. Anant Jani. Thank you so much for being here today, Anant.
Thanks very much for hosting me, Rihanna and Taylor. Great to be here.
So from your biography, your early career included starting off as a PhD researcher in immunology at Yale. How did you find yourself moving from that to research in value-based healthcare and working in the Oxford Global Surgery Group?
Yeah, so it's quite an interesting journey. Towards the middle of my PhD, I love science, but towards the middle of my PhD, I started realizing that a lot of the systems that we were working on were quite artificial, and their relevance for human biology was sometimes limited. And so I had this notion of how can I actually do research that's much more relevant for human health? So that's when I started exploring the idea of actually going into medicine. And when I started reading a little bit more about it, I was talking to some friends who were in medical school at the time, and they were telling me about policy changes. And this was probably 2007. There was a lot of hype and hope around universal healthcare in the States. And I watched this movie by Michael Moore called Sicko, which was looking at the state of healthcare in the US versus universal healthcare systems. And that was the first time I was actually exposed to this notion of a universal healthcare system. So then I started digging a little bit more, and then I read what was called the Commonwealth Fund Report, which showed that the UK healthcare system had one of the best healthcare systems in the world when you look at a variety of different metrics, and the US was like dead last. And then I started learning a little bit more about universal healthcare systems, and I got more and more excited about this idea of becoming an academic clinician, where I would spend some time in the clinic with patients, and that time in the clinic with patients would inform the questions that I would ask on the bench. Then got this idea in my head to apply for medical school, and I only applied for medical schools in the UK, and I got accepted to Oxford, and I finished my PhD in 2009, and then I started medicine at Oxford in 2009 as well on the graduate entry program, which unlike the traditional programs in the UK is 4 years. So we have 1 year where we learn the sort of basic science stuff, and then years 2, 3, and 4 we integrate with the regular medical students, and we do our clinical work with them as well. The first 2 years the first year I really, really loved, because we were able to work a lot with patients, and that was my first exposure to patients. As a scientist, I had more exposure to mice than I did humans. And so this was an opportunity to actually work with patients and talk with them and actually understand about the sort of healing art of medicine. Towards the second year, after I did a few more rotations, kept reading about universal healthcare systems, and I started sort of digging deeper into healthcare system function and organization, and then also public health. There were certain things that started bothering me. Like you do your rotations and you'd see like a 75-year-old or 80-year-old on, 15 or 20 meds, and they had no idea what meds they were actually taking. You'd ask them what medications you're on. They'd say, oh, well, I'm on the red circle, the green triangle, the white oval. They had absolutely no clue what medications they were taking. And, oftentimes you'd find that they were on a primary medication. They're on 5 primary medications for a condition. So the medications were for the side effects caused by the primary medications, and they would take like 3 or 4 pills on an as and when needed basis, for painkillers or for sleep or something like this. Towards the second year, I started getting a little bit disillusioned. I had also started exploring other options while I was doing the medical training. So I joined a group called the Center for Sustainable Healthcare in Oxford, looking at the impact of healthcare on the environment and vice versa. Started working with other clinicians as well on a variety of different projects, just trying to expand my horizons and really trying to find myself. Towards the end of the second year of medical school, I realized that it definitely wasn't for me. So I deferred for a year, trying to figure out what the hell am I going to do with my life? So I sort of had this notion of becoming an academic clinician, and I thought that, this was my path. And now all of a sudden I find that it's definitely not it. So it was almost a shock. I just needed some time to sort of, I guess, find myself, as you say. So I then started, I wasn't doing medical school. I was still in Oxford, but I had kind of a year to just do stuff. So I started doing a bunch of random stuff, which had nothing to do with science or very limited stuff to do with medicine. I was working with coffee bean farmers in Mexico to look at how they could use technology to get fair prices for their coffee beans. I was working with farmers in Siberia, looking at the trade that they would, so they would harvest pine nuts, for example, and then they'd use that to get dollars on the black market, and just looking at that dynamic. I was working with some people in Senegal who'd been displaced by a mining company, working with some lawyers to make a case for the legal rights for the people who've been displaced. And then one of the projects that I was working on with the Center for Sustainable Healthcare, almost tangentially, was looking at the impact of climate change on healthcare. I did a project on that, and I was giving a talk at a conference at the exam schools in Oxford. This was probably 2011, during the spring or summer of 2011. And I did my talk, and there was a chap in the audience who actually was one of the founders of the Center for Sustainable Healthcare, Sir Muir Gray. And he came up to me afterwards, and we had been in email exchange a little bit. And he gave me a torn off sheet of paper, which I still have, with his name and number on it. And he said, "Give me a call. I think we might be able to work together." So I gave him a call, and then I started working with him probably August or September 2011. He was leading a program in the England Department of Health called the Right Care Program, which was looking at how England would recover from the 2008 global financial collapse. And the key thing there was we needed to reduce the amount of money that we were spending on healthcare. And how could we reduce the money that we were spending on healthcare, but keep the outcomes the same? And so that's the core principle of value-based healthcare. So that, in a very long, rambling way, was my introduction to value-based healthcare. So I did 2 years formally in the Department of Health, working on the Right Care program. And then I transitioned to working with Muir and running a company that he created called Better Value Healthcare. And I ran that for about 8 years. In the interim, while we were running the company, we also set up a program at the University of Oxford, the Value-Based Healthcare program, in 2015. So yeah, that's how I sort of got into value. It was a very long, circuitous, sort of scatterbrained route. And how did I get into global surgery? Well, that's interesting. So office that we had for Better Value Healthcare was in the same place as the Cochrane collaboration, the UK Cochrane collaboration, which is in North Oxford. We were on the same floor, and Roba, who you know, and who's sort of, I don't know, I guess one of the founding people or members of the Oxford Global Surgery Group, was doing a project there in, I think it was 2013 or 14. She had a placement with the Cochrane collaboration. And she came by our offices, we chatted about what we were doing, and she knew Muir, et cetera, et cetera. And then, we'd see each other off and on at various events because, we had a common network. When I exited the company, Better Value Healthcare, in 2019, I reached out to a chap called Richard Cantor, who's an ENT surgeon, and told him that, I'm looking for some teaching opportunities if there is anything. And he, I think, had happened to meet with Roba the week before. And so he put me in touch with Roba again. And then I met with Roba, and that's how I got involved with global surgery.
Sounds like a lot of maze, but ultimately going in the right direction, right? And I think that's truly though how a lot of our careers go. I actually wasn't originally going into medicine either, and it's just like a process, and you go and you pivot as you learn things, and frankly, that's what global surgery is about as well, right? Like global surgery isn't necessarily ideal, like just doing this one thing and this is exactly how it all goes. You have to kind of roll with the punches and learn and grow. And I think that's great that you were true to yourself. And when you realized that something wasn't for you, or that you saw something that was broken, that you're willing to kind of take the plunge to try and make it better. So you talked a lot about value-based healthcare, and I think that is a very, very relevant topic for all of us, both in global surgery and outside global surgery. As you mentioned, in the States, healthcare costs are exploding, but then around the world, for example, in low resource settings, there just isn't even resources, period, let alone like whether it's value-based or not, right? Do you think for our listeners, would you kind of be able to describe what value-based healthcare is and how it's relevant to maybe global surgery or global health efforts?
The basic notions around value-based healthcare are not new. It's a new packaging, but the basic concepts have been around for decades, namely improving patient outcomes, improving population level outcomes, and optimizing resource utilization. So those are things that Avidas Donabedian talked about in the 80s. This is a basic notion that all of healthcare is driven towards improving patient outcomes, improving population level outcomes, and optimizing resource utilization. So delving into those just a little bit, improving patient outcomes, or what we term as personal value, that's meeting the objective clinical needs of the individual, so reducing their HbA1c or making sure that there are no complications post-surgery. But it's also addressing the subjective needs of the individual. So, for example, are they able to golf post-knee replacement? Are they able to play with their grandchildren? Because these are the sorts of things that are most important to them. Population level outcomes. This, I think, is particular to universal healthcare systems, where the healthcare system has a mandate to provide care to the entire population at the point of need. And it's a matter of equity that a given patient, regardless of where they are or what their circumstances are, should have access to the same outcomes. And so from a population outcome perspective, we're thinking about unmet need, and we're thinking about equity and equality. And unmet need is sort of nuanced. So if I give an example, you're the doctor, I'm the patient, I have type 2 diabetes, I come to you, you deliver fantastic outcomes to me, you give me a great consultation, so you've delivered personal value to me and you've delivered fantastic patient outcomes to me. But my next door neighbor also has type 2 diabetes, it's the same age as me, and almost, very similar in terms of profile, etc. But she does not go to you. Now, in a non-universal healthcare system, you don't technically have a responsibility for my neighbor. But in a universal healthcare system, you do, because she's part of the population. And that is an inequitable distribution of healthcare resources. So now, obviously, there's two things to that. One is her care-seeking behavior, and then two is actually delivering the outcomes to her to ensure that she's able to be healthy. And then finally, there's optimizing resource utilization. And I think the key there is defining what we mean by resources. So typically, when we think of resources, immediately our minds think to, shift to money. And money is certainly one component of resources, but the others are time, the use of space, and the use of carbon. If we go to the use of space, then, that's obvious. You would want to allocate the space or the beds to the people who need it most. And you need to make these really tough decisions. And I think the COVID situation has been a real case in point and a wake-up call there where physicians have had to make really tough decisions about who gets ventilators, et cetera, because you have a limited number. Then when we look at carbon, obviously there's a carbon cost to all of the care that we deliver, from the nurses and the doctors having to go to the hospital, to the patients having to come to the hospital, to the supplies that we purchase. And then finally is time. And when we think about time, obviously the first thing usually that comes to mind is the time of the healthcare professional. But the other element of time that we need to take into account is the time of the patient. So if I give an anecdotal example of one of the members of our team, her father hurt his back, and they live in a place called Whitney, which is on a good day, probably about a 25-minute drive to the Oxford Hospital. But on a bad day with traffic, which is most of the time, it takes about an hour and a half to and from. So you have 3 hours driving to and from the hospital. Their doctor was late by about 2.5 hours, so that's 6 hours. And then they had to wait for about 3 hours to get their meds at the pharmacy. So that's 9 hours. And of course, the hospital has cafes and things like this, so they were able to sit down and work and chat. But that's 9 hours of citizen time times 3, because it was the daughter, the father, and the mother. So you have 27 hours of citizen time in the palm of the healthcare system's hand. And it's this economic concept of negative externalities that we oftentimes don't really pay attention to in healthcare. And this is something that I think we really need to start paying more attention to. If we take this notion of value-based healthcare to resource-poor settings, I think it's even more important because they have fewer resources and they need to make those resources go much further, number one. And number two, the opportunity cost or the negative externalities of healthcare are huge for citizens in resource-poor settings. when you consider the fact that they may need to actually travel a full day to get to the clinic. And then if they have to go back to get the results, it's even longer. And if these people are living hand to mouth and they're on, below the poverty line of $2 a day, then they lose an entire day's worth of wages. And so, they have to make a really critical decision as to, do I feed my children or do I go to the hospital? And so I think from a healthcare systems perspective, this is something that sometimes is sort of, maybe not paid attention to enough. And I think it's something that we need to be more mindful of. I think in resource poor settings, low and middle income countries, I think value-based healthcare can actually help the systems to leapfrog the Western systems, because the Western systems were set up to tackle acute conditions oftentimes. And so we have a very hospital-centric view of healthcare, maybe not necessarily the best use of technology either. And in resource poor settings where you have nascent healthcare systems, I think there's a real opportunity for them to learn from the mistakes and the successes of Western healthcare systems, bring on the successes and bring on the positive lessons, avoid the mistakes, and then also augment their systems with the new technology that we had, that we have currently that weren't in place when the Western healthcare systems were being set up.
I really agree with what you're saying there about how when we think about global health and global surgery, a lot of what we do comes from the provider perspective, because a lot of the research and the work that's going on is led by the providers. I think this probably becomes more difficult when we talk on a global scale, because the cultures that we're dealing with are very different to our own oftentimes. And we don't necessarily recognize what's important to the patients who are meant to be at the heart of all of these initiatives. So I guess that leads to my next question, which is, actually, when we talk about healthcare globally and global surgery, how can we make sure that we do keep the patient at the heart of these initiatives and not just keep it entirely from the provider perspective?
Some of the work on shared decision-making and silent misdiagnosis by Al Mully is based at the Dartmouth Institute, but he also spent some of his time in the UK now. I think this is where that work is actually quite important, and this notion of shared decision-making, physician or the clinician actually has a consultation with the individual patient and their family and their carers to actually elicit three things: the ideas of the individual patient and their family, their concerns, and their expectations. And this is a very simple heuristic, ICE, ICE, ideas, concerns, and expectations, where if we were able to systematically ensure that we were able to elicit, capture, and hold ourselves accountable for the ideas, concerns, and expectations of the individual patients and the families that we're working with, I think we do a much better job of actually taking this into account. Al Mully's work on the silent misdiagnosis sort of hammers home the point that we really do need to do a lot more on shared decision-making and actually understanding the needs, preferences, and ideas of the patients that we're working with. The silent misdiagnosis, this concept is, say you're the doctor, I'm the patient, and I come to you and I say, Doc, I'm really anxious. I'm losing sleep. I can't sleep properly. Now, in a rushed consultation, you may ask me, a few questions here or there, but you don't get to the root cause. You think I'm anxious and you think I'm losing sleep. So your first line of intervention might be to give me some pills to help me sleep. Okay. And then you send me off on my way. But you haven't asked, why am I losing sleep and why am I anxious? Well, it's because I just lost my job and I have no idea how I'm going to get another job. And it was my dream job. I really loved it. And now I'm just completely lost and I have no idea what I'm going to do. And if you elicited that need of mine, then maybe what you would have done was to refer me to a career counselor or something like this, or to jobs benefits or jobs placement training or something like this, because that's what my real need is. Now, this is not all on the sort of clinician's shoulders. It's also a responsibility of the individual patient, in the sense that they need to be able to articulate what their actual need is. Sometimes that takes time because it may not be clear in their head either. And so developing this relationship with the patient and that trust, where the patient feels that they can trust the doctor as a confidant and as a resource, I think is essential. Then I suppose the other thing is things called PSPs, or priority setting partnerships. Sir Ian Chalmers worked on with the James Lind Alliance and the James Lind Initiative, which is basically that when we're coming up with interventions for healthcare, we're oftentimes basing it on evidence. The evidence is derived from the research questions that we ask. But oftentimes the research questions are driven by all sorts of other interests. The interests of the clinicians, the interests of pharmaceutical companies, of investors, etc. And what Ian Chalmers and the James Lind Initiative did with the priority setting partnerships was to bring patients into the discussion about setting priorities. For research from the get-go, what should we actually be researching? When you're looking at public sector money going into these national organizations that are funding research at a national basis, whether that be the NIH in the States or the NIHR in the UK or the MRC in the UK, how is that money flowing to research questions that are actually going to be of most interest to patients? And, that's shaping the demand of the entire system to focus more on the needs of the individual patients. So that's sort of a macro level. And then at the micro level, you have the shared decision-making stuff and the silent misdiagnosis that I talked about. So I think tackling at both ends is actually quite essential. And in resource poor settings, yeah, it is difficult because, even in the UK, right, it's taken us a long time to get here. And we're still making mistakes and we're still learning and we're still trying to refine our models. The UK has not always been such a great place, right? So if you read any Dickensian novels, you'll realize that England was actually not the safest place. Life expectancy wasn't very high. Conditions for workers were very poor. There was child labor, which was fairly rampant across the country. But we gradually started changing these things and improving the situation in this country. I mean, in resource poor settings, I think rather than trying to get to the stage that the UK is at right now, taking small, simple steps to start on that journey is essential. And I think many countries are doing that. And I think, perhaps again, utilizing technology, not saying that technology is an end in itself, but it's a means to an end. But if technology could be used in a more creative way, maybe a more productive way, then maybe that could help to augment how systems actually pay more attention to the needs of their citizens.
Yeah, I mean, I think this is a really interesting concept, trying to better understand the needs of the population you're working with. I mean, there's so many different things that are going on. And as you highlighted, like, for example, someone having to take a day off of work to be able to come in to see the doctor, perhaps in a high resource setting might not be that big of a deal. Or there's often obviously poor people all around the world or people who are struggling to access healthcare, but hopefully there is some sort of safety net in a lot of these high income countries where there's Medicaid or something like that someone might be able to fall back onto if something catastrophic were to happen or they needed to take these days off. But in a lot of these, LMIC settings, they don't. If something like that happens, there is no backup for them. There is nothing for them. And then they're basically thrown into poverty, and if they weren't already, and then, pretty much destitute. So I do think one of these values that you were talking about, a value-based healthcare system, of personal value, how to understand the needs of your patients is super important. And so when we talk about healthcare globally, we have a lot of different variety of cultures and things that are coming in to shape those patient needs. So how do you think we can best take into account these cultural differences, these cultural aspects, and as well as the money when trying to implement healthcare interventions on these global scale?
It's a huge question.
So ready, go.
Yeah, ready, go. Okay.
Solve all of healthcare problems, please.
Okay, I'll preface it by saying I have no idea. And then
if we did, we would have fixed it by now, right?
Yeah, one would have hoped.
Yeah.
One would have hoped. I think they're just small steps. I mean, again, you've left me speechless. It's such an important and fundamental question. And the risk is giving some sort of simplistic answer. Okay, so I suppose maybe one conceptualization to view it as a commons. Okay, so if you're familiar with any of Elinor Ostrom's work, Elinor Ostrom was based at the University of Indiana, and I think she was the first woman to win the Nobel Prize in Economics. And you've probably heard of this concept of the tragedy of the commons, which Hardens wrote about, which was that you have, for example, a lake with some fish in it. Nobody owns the lake. It means everybody owns the lake in a community. And each individual fisherman feels that it's their right / goal / in their best interests to get as many fish as they possibly can. And so if each of these individual actors are acting with that perspective in mind, the lake will be depleted of fish and there will be nothing left for future generations. And that is the tragedy of the commons, that it's owned by nobody, which means it's owned by everybody, and everybody acts in their best interests rather than thinking about the good of the whole. So if we then take that and expand it out to a universal healthcare system, to keep it simple, and then I'll expand to resource poor settings where you may not necessarily have a universal healthcare system, you will have societal aspects that you need to pay attention to. So Elinor Ostrom, the definition that she uses in a book called Governing the Commons, so just taking one step back, the reason Elinor Ostrom won the Nobel Prize was she did a bunch of field work across the world to demonstrate how communities overcame the tragedy of the commons. She did this field work and she wrote a fantastic book called Governing the Commons. And there's 8 steps, I think, that she talks about, that she identified as steps where a community can come together to successfully manage a commons sustainably. And if we take the definition that Ostrom uses in her book, a commons is a man-made or natural resource shared by a community of appropriators. Okay? A man-made or natural resource shared by a community of appropriators. So let's take that step by step. It's either man-made or natural. So a universal healthcare system is a man-made resource, okay, shared by a community of appropriators. So the appropriators are the ones who can actually claim that resource. So in the context of a universal healthcare system, who are the appropriators? Well, they're going to be the payers, they're going to be the providers, and they're going to be the patients. If we look at it from that perspective, each of those appropriators has a role in maintaining the commons. It's not just the job of the payers, whether that be an insurance company or a tax-based system like a universal healthcare system that we have in England. It's not just going to be the providers, i.e. the doctors, the nurses, etc., who are making a decision about whether to prescribe a pill or to order an X-ray or to order a blood test, etc. It's also going to be the patients, because they're also going to be putting themselves at risk. So, for example, they know and are aware that smoking is bad for them, but they continue smoking. Then they are an appropriator of resources in the future that could have been avoided and could have been made available to other people who may have needed it more, or to make it available for the future. This concept of a commons might be a way of thinking about a healthcare system where everybody is responsible for it and everybody has a role to play in the resources that they extract from it. If we then expand this to resource poor settings, which may or may not have a universal healthcare system, there we see the healthcare system as part of a larger whole, right? The healthcare system is there to keep people healthy. And if people are healthy, they can keep doing their jobs and keep society running. Whether it be the farmers who are farming and making food for the other individuals and for the doctors and the nurses, or the postal workers who are distributing the mail, or the garbage collectors who are taking the trash and are actually probably one of the most important public health professionals, although they're not labeled as such, because sanitation and hygiene are so important for health. So I guess a long rambling answer to your question is, if instead of creating these silos within these different elements of society, if we were able to come together as a whole and actually have these open discussions and dialogue about what our priorities are and where we should be spending our resources and what's most important for us. Should we, for example, be spending, in England, 130 billion pounds on healthcare? Should we make 3,000 more GP spots available in England, for example? There's a resource to that. And if I, sort of give an anecdotal example in this country, a GP gets paid about 96,000 a year on average in England. And a teacher gets paid around 30 to 40K a year. And in many secondary schools in England, particularly, and definitely in Oxford, which is where I live, they no longer offer PE or physical education courses because they can't afford to pay the teachers. So we are making money available for 3,000 more GPs, but we're not making money available for physical education teachers and more teachers and the salaries there. So you could pay for about 3 teachers for the cost of 1 GP, roughly, right? And who's making those decisions? Because it's all coming from taxpayer money. So how are we deciding that we want more GPs rather than teachers? And the teachers, if they were able to teach children physical education, we have a rising childhood obesity problem in England. that could help to stem that. It could also help to educate the children about healthier behaviors, etc. So how are we making such decisions? So in these resource poor settings, if we were able to have a situation where there was the ability to have more active dialogue and discussion, to actually elicit and hear the needs of the people on the ground, and this is where social determinants come in, that actually we don't need more doctors, we don't need more surgeons, we need more nutritious food for our children. So give us a chicken so we can get some eggs, for example. Give us some seeds so we can plant them and grow our own food, for example. Give us a small plot of land. Give us some mechanism to actually have cleaner water, because all the water that we're drinking currently is dirty.
And I think what you're saying kind of fits a lot with what people are thinking right now in the global surgery paradigm, in that the surgery itself is only one part of the huge infrastructure that does produce health. So someone like the person who picks up the garbage may be far more important than a surgeon, or an anaesthetist or an obstetrician. Although I guess our tendency is to always side with the group that we belong to, and everyone's fighting their own corner saying we are the most important. And actually sometimes we need to take a step back and see what is actually affecting people's health. You mentioned social determinants of health, which kind of brings us on to our next session really nicely there, with your work looking quite a lot at social determinants of health. Do you mind briefly explaining what those are and what your work in this area has been so far?
So social determinants, if you look at health outcomes, 20% of health outcomes are due to access to healthcare facilities, doctors, nurses, hospitals, GP facilities, pharmaceutical medications, etc. And about 80% are due to these social determinants of health. So education, jobs, access to clean air, access to clean water, access to nutritious food, looking after domestic abuse, crime, substance abuse, etc. These are the things that account for about 80% of health outcomes. If you look at most health and care systems, I think there was an OECD report in 2018 which demonstrated that less than 3% of healthcare systems budgets actually go to health promotion and disease prevention. The rest go to symptom management, so doctors, hospitals, nurses, etc. And so this notion of social determinants is trying to address some of these root causes of illness, like the example that I gave about the silent misdiagnosis. I'm anxious and I'm losing sleep because I lost my job, not because I have a sleeping disorder. And so giving me pills to help me sleep is just sort of scratching the surface of the root cause of my problem. And so trying to address these social determinants will go a longer way of actually addressing health needs of the population than actually looking at the surface of the symptom management, which we typically do. My work in social determinants focuses mostly on a couple of things. One is looking at something called social prescriptions, which is becoming popularized in England, where you're the doctor, I'm the patient, and we use the same example of me being anxious and losing sleep. Scenario number one is you give me pills to help me sleep, and then you give me an information leaflet that gives me some information. Scenario one is you just give me the pills, okay? Scenario two is you give me the pills and you give me an information leaflet about how to manage my anxiety. So breathing exercises, etc. Scenario number three is you do a deep root cause analysis and you actually find out the reason why I'm anxious and losing sleep is because I've lost my job. And in that instance, in that scenario, you don't actually give me any pills to help me sleep. You give me the information leaflet. And in addition to that, you prescribe me a jobs placement prescription, where I then go to the jobs placement center and they help me to actually find a job, because that's the thing that's really bothering me. And you can have a social prescription for a variety of different things, all tackling these social determinants of health. And there's a variety of social prescriptions available, delivered by VCSE or voluntary charity sector organizations. I mean, this is nothing new, right? This was actually, I think the notion of social medicine was first coined, I think it was 1848 in France and Germany at the rise of the Industrial Revolution, because what they were finding was that a lot of people were getting sick, and they were coming from the countryside into the cities to get these jobs, and they were in these awful conditions, poor housing, etc. These were the factors that were actually making them sick, any inherent illness. And so it's tackling these sort of root cause illnesses. So I'm working with NHS England currently, looking at the use and impact of social prescribing across England. And then there's another project that I'm working on, looking with the Oxfordshire County Council and in Newcastle, looking at the use of green spaces to promote health, both physical and mental health. And then there's another project that we're working on, looking at the future of cooling And the idea there is climate change and severe heat will negatively impact millions of people, and this impact will be unavoidable. I mean, what's perverse is that you could almost see cooling as an intervention to keep people who are exposed to severe heat in a cooler environment. But if you're using dirty coolants, you're releasing CFCs into the atmosphere and actually exacerbating climate change and global warming. And so the first thing we're looking at is, what is the impact of severe heat on morbidity? The impact of severe heat on mortality is fairly well established, but the impact on morbidity is not as well established. So that's what we want to establish. And then what we want to explore is, do we need to explore cooling as an intervention in the future if the planet just keeps heating up? And what would that actually look like? And so there, cooling can be sort of disaggregated into active cooling with air conditioners and fans, and passive cooling. So having higher roofs, changing the direction your windows face, closing shades, etc., to keep your place cooler. And we want to see what are the best clean cooling strategies that we can try to implement on a system-wide basis to keep people less exposed to severe heat.
This is fascinating to me. I actually lived in India for a period of time, and during one of the times that I was there was a giant heat wave, and it killed hundreds of people in the area. It was on CNN and everything. And I thought about that. You know, a lot of the people who were dying were not just your average person walking down the street, right? They were the vulnerable, the people without housing, or, you know, having extreme exposure to this heat, as you said, no cooling, no fans, no things like that. So can you tell us a little bit more about how you talked about these two different categories of passive and active cooling? What have you guys tried to roll out, and where is this being tried at, I guess?
We only started the program October last year, so we haven't rolled any out yet as an intervention.
Sure.
What we want to look at first is just what is the base case. So, you know, I think the heat wave that we had a few years ago in Europe killed a few thousand people in France, and it killed a few thousand people across Europe, actually. Last year, we also had a heat wave, and we know some of the mortality statistics, but we know very little about the morbidity, i.e., you know, people getting sick or some of their conditions, pre-existing conditions, getting exacerbated, and then their utilization of healthcare resources. So like we have in the winter, so there are fuel subsidies that we provide in the winter so that people can keep their homes warm if they're not insulated properly. And we give these subsidies for heat in colder weather. And in the future, what we want to explore is, do we need to create this type of thing for severe heat? So we know what the morbidity, mortality statistics of cold are, but we don't know the corollary for severe heat. So that's what we want to try to establish first. And so in the program, we're looking at England and France right now. We want to expand it to resource poor settings because, like you said and pointed out, that's where there are going to be many, many more vulnerable people. But the data that's collected there is also not as robust. So we wanted to start off with systems where we knew the data was robust and we could trust it. And then from there, expand out to start looking at some of these interventions. In terms of active cooling, the Kigali Cooling Efficiency Program, KCEP, has come up with a list of dirty coolants and clean coolants. And they're trying to transition countries to making a commitment to just using the clean coolants. So that's one mechanism whereby we can look at clean cooling. The other is, what is the energy source that's utilized to actually supply energy to the active cooling? So whether that be air conditioner or fan. And there's an exploration of looking at solar power, for example, to supply the energy for the active cooling. And in terms of passive cooling, one of the people in our group is actually looking at the use of vernacular cooling. And so basically what that means is that, you know, if people are hot, they don't need somebody from the UK to tell them, hey, you're hot. They're probably going to come up with strategies to try to keep themselves cool. And so, you know, the goal there with vernacular cooling is to try to understand what strategies have people been using to successfully keep themselves cool in these hot environments when they don't have access to active cooling. And then to see if we can roll these out more systematically and educate the population, because these are homegrown solutions. So it's sort of like a positive deviance approach. These are homegrown solutions, so it's much more likely that people in the local context will adapt them. And then the second thing is to see, can we use technology, for example, to augment these vernacular cooling mechanisms, which hopefully are passive, so they don't actually use any energy whatsoever. But we haven't gotten started on those aspects yet. So But that's certainly something that we want to explore and more actively work on.
So I can say I've definitely learned a new phrase today, because I can genuinely say I've never heard the phrase vernacular cooling. I think it's really interesting, because I think a lot of people would never have guessed that link between cooling and health. But actually, the more you describe and the more you think about it, actually a lot of these places we speak about are low and middle income countries, and they have more tropical climates than we necessarily get in where we're based, actually here in the UK. And I think you're right in that the first step in anything is just what is going on. So what is the data? And there is a huge data gap in a lot of these things that people haven't thought about doing before. I think social determinants of health is a really interesting avenue, because it's about treating the health problem before it becomes a problem. With your experience, I mean, what are some of the determinants of health that you've seen that are very impactful that people haven't really thought about doing much with?
I think nutrition is probably one of the most important. It's just essential. So sanitation, hygiene, and nutrition, these are things that people have thought about and they know about and we talk about, but we don't invest enough resources or money in. So I would say that would probably be a starting point, I would say, for any system, is just to make sure that your people are properly nourished and they have access to clean water. And again, I'm not the first person to say this. I won't be the last person to say it, but I just don't think we're investing enough resources into those areas. And I think there's definitely a lot more need for resources. If I go to global surgery and social determinants and my work with the global surgery group and global surgery generally, I remember one of the colleagues talking about children and younger adults getting these gruesome electrical burns because of uncovered wires. And the notion that, we need to train up the surgeons in these resource-poor settings to understand how to treat these burns and provide an intervention for these people affected as quickly and as safely as possible. So, I mean, from a healthcare systems perspective, typically, if you have supply side, demand side, where supply side is healthcare providers and interventions, pharmaceuticals, etc., and you have demand side, which is why are people getting sick in the first place? Most of our focus, and this is what the OECD report says, is on the supply side. We're thinking, okay, let's train more doctors. Let's get more trauma surgeons there. Let's get more plastics there to ensure that anybody that gets an electrical burn is able to get healed quickly. Road traffic accidents is another example. Let's get the trauma surgeons there. So if you have a road traffic accident, you can intervene early, get the person saved, give them some basic training in neurosurgery, etc. Now, from my perspective, what I would see is that's all supply side, but why aren't we looking at demand side? So why aren't we getting policies in place that demand safer electricity such that the wires are covered? So you don't have any electrical burns, full stop. Why don't we look at better roads? So the uneven surfaces that these people who have to ride motorcycles are exposed to are no longer there. Why don't we get some much more robust and rigorous helmet laws, such that if somebody is caught not wearing a helmet, they get a fine for like 10 days wages or something like this. So again, looking at supply side, demand side, let's reduce the demand rather than trying to augment the supply for something that's preventable. And I think that would be a huge step for global surgery generally, if we were able to prevent all the preventable conditions. Now, this is taking surgeons out of their skill set. It's requiring a shift in mindset. So it's taking them out of their skill set that they've sort of thought that this is all I know how to do. I know how to do surgery. But this is, what I'm talking about is not rocket science, it's common sense. And so, if they were able to shift their mindset and say, actually, I need to create these skills within myself as well, to go to policymakers and demand that we have new regulations for electricity supplies, and that if anybody is caught having open electrical wires, they're fined or they're shut down, then the global surgeon will probably have a much greater impact. Because if we go back to one of the original questions about resources in resource-poor settings, if you have a preventable condition, like an electrical burn, and you have another woman who has breast cancer who needs surgery, in that scenario, you're probably going to go to the person that has the electrical burn. But if that person with the electrical burn didn't exist because the electricity wires are covered, and that person never had the electricity burn in the electrical burn in the first place and didn't need surgery, then that surgeon's time could actually be allocated to this woman. So you're able to make your resources go much, much further if you were able to look at some of these things that are preventable.
This is such an interesting topic because we've been brought up on multiple of our podcasts thus far of this idea that, especially in low resource settings, the surgeon takes on a much more broad role, right? They're not just the surgeon. In some of these high income countries, you're pretty siloed, and I just do hips and knees, or I just do this, right? Like that's all I do. But for example, we had a doctor on who worked in a conflict war zone, and he had to be the technician to fix the machine. He had to be the surgeon, the anesthesiologist, and the coordinator of where they're going to move people because the hospitals are getting blown up. So the surgeon takes on a very different role, as you're saying. They need to be able to think about some of these other skills that might be useful. But that shouldn't just be limited to low income countries, right? We shouldn't just say because we're siloed in maybe a high resource setting that we shouldn't think about other things, or at least how to create synergies across organizations, across fields to work better with our tech. We have a technician, but how can we work better with them to help them do their job better, right? Or to make their job easier for them. So what are some of these skills that you feel, besides advocacy, that surgeons maybe should try and cultivate to be able to be that more of a global surgeon?
Reading more broadly, maybe as a starting point, and expanding their knowledge on different topics in different areas. So looking at health economics, looking at nutrition, looking at, these sorts of things. I would say for me, knowledge is always the starting point. It's step number one. So if the global surgeon was able to, again, with their very limited time to augment their knowledge, then it could very quickly broaden their perspective. The other is to ask more questions, maybe. And these are very simple things, knowledge and questions. But I think there's something that anybody can do, and you can do over the next, 30 or 40 years, or however long your career is going to span. And by questions, I'm specifically thinking of Taiichi Ohno, who created the Toyota production system. And in the Toyota production system, everybody's responsible. And again, this is this notion of a commons. Everybody is responsible for the entire assembly line. So if you're at point number one on the assembly line, you have to think and project, how will my actions impact persons at positions 2, 3, 4, 5, and 6 of the assembly line. And in the Toyota production system, they created a mechanism whereby anybody in any of these steps could actually stop the entire production line if they noticed that something was wrong. So what Taiichi Ohno taught his people in Toyota was to ask why 5 times to get to the root cause of a problem. So why? If you see something that's gone wrong in step 5, then ask, why did that go wrong? Oh, well, it could have been that this thing in step 3 actually went wrong. Okay, well, why did that go wrong? It's because the technician didn't know how to do this properly. Why did that happen? Oh, because they weren't trained properly, because this is actually a new technique. Okay, so that's what we need to do. We need to train this person at step 3 to ensure that they are able to get this part manufactured properly so that there's nothing wrong in step 5. So very simple, just augmenting their knowledge and broadening perspectives. And then 2 is to ask more questions. And this heuristic that Taiichi Ohno has created of asking why 5 times, I think is something that I use. And I find it's really helpful in trying to think deeper about why something is actually happening.
Yeah, I completely agree with that thing about asking questions. And it's, part of the reason that we thought to start a podcast like this, and it's asking the right questions to the right people. Speaking to people like yourselves and some of the other people we've had on the show, just to share their perspectives from a different sector almost. Because I think healthcare can be one of those ones where you see a lot of the tech industry and people like that taking this lean methodology, but perhaps healthcare hasn't been so quick on picking that up. Something I just wanted to come back to, which you mentioned earlier, was just about how countries are leapfrogging and how we can be learning from these countries that are able to progress that little bit faster because they haven't had the sort of background and all of these systems in place that it's harder to switch from rather than creating a system anew. And one thing that your biography said is that you've worked previously with healthcare systems in the Middle East and actually allowing those systems to focus more on value-based healthcare. What are some lessons that you've learned from this that you think could be relevant to the low and middle income country context?
I guess that the key thing is just being clear on the strategic intent of your system. By that, what I mean is going back to the very early definition of value-based healthcare, simply looking at patient outcomes and population-level outcomes. So as a starting point, defining the outcomes that you want to deliver to your citizens. And outcomes, not outputs, not the number of consultations that I've done, the number of nurses that I have, the number of doctors that I have, the number of beds that I have. Not that. I'm talking about outcomes. So how many of my citizens are able to be properly nourished? How many of my citizens, if they've broken their leg, are able to get their leg mended and are able to go back to work and earn a livelihood? It's something that we don't do in our systems. And if these nascent healthcare systems were able to get these metrics thoroughly integrated into how into their systems and hold themselves accountable for these outcomes, I think it would also tackle some of the questions you were talking about, in terms of how do we ensure that we're actually meeting the needs of the individuals who are coming into the system, for the patients, et cetera, et cetera. That requires active dialogue and discussion. It requires that the system comes together, discusses the priorities, and then holds itself accountable for those priorities. And when I say holds themselves, I mean the individual citizens as well. Because if there's risky behavior that they are undertaking that might expose them to some sort of harm that would then require healthcare resources, i.e. Somebody riding a motorcycle without a helmet, then if we again take this notion of a commons, they are appropriating resources that didn't necessarily need to go to them.
Thank you so much. I really think that you've hit on some interesting things that I've been actually thinking about over the last couple of weeks. I think the thing that's been striking to me is you're not just going in and trying to institute a solution that you feel is best, but work with the people and the context of where they're coming from, meet them where they are. So, for example, you said like with the passive cooling, while it would be great to have air conditioning units for everyone, that's probably not feasible, first of all. And as you said, what is the carbon impact that we make by doing that? So not just on a financial level, but on a societal level, that might not be the way that we can do it. But where can we meet them where they are and figure out local solutions for them?
So they have to be going on this journey, and they have to recognize that, because I'm a here today, gone tomorrow phenomenon, right? I'm not in their government. I'm not delivering healthcare there. Even for global surgery, right? We have to just be careful about having this inflated sense of importance of our contribution to it's their systems, it's their journey. Because these changes, if we go again back to Dickensian England, are going to take decades to institute. And they're the ones that are going to have to feel the pain, and they're the ones that are going to have to keep following up on stuff and keep hounding people, et cetera, et cetera. This is, maybe a slight augmentation, and then we can learn, and then we can maybe put other people in touch, and they can create these sort of strong networks. I think it's definitely their journey, not ours, and we can help a little bit along the way. And we just, I think, need to be really careful about not giving solutions. I'm doing air quotes, realizing that there's a podcast, because I don't think there will be temporally and geographically normalizable solutions across different contexts. They're definitely going to vary, but what will not change is the outcomes. So I think as a global community, we can define outcomes, and that I think we can spread across healthcare systems. But the means to delivering those outcomes will vary based on context. And that's what they need to figure out. And we can help them and support them, but they ultimately need to figure that out for themselves.
This isn't us coming to just help them. It's a two-way street. They help us, right? I've learned so much in my time abroad that I've taken back and seen the holes in my system, right? Where we think ours is perfect and we're just going to help theirs. I actually learned no, actually, we have lots of holes too that are actually filled often better times by the solutions that they have. So it is a two-way street, and it isn't something that we just come in and we are helping, and that it really is a collaboration, and that we're there to work with them and to just help in whatever way that we can. So I think you're totally right. This is their journey.
I echo Taylor's view there. And I think just looking at the work that you've done, even with the vernacular cooling, and what you're doing is looking for solutions rather than giving solutions, which is exactly the sort of ethos that we need to all have when it comes to this sort of thing. I think coming from the field and the background that you have had, it has given you that ability to step back and allow people to help you with that. Whereas I think perhaps a problem being a clinician that I've personally seen is that people feel like they know something and they know that it's right in their context. They assume that it's right in all contexts. And I think this is one aspect where clinicians and healthcare providers can be learning from other people in other sectors. From yourself, I know obviously you have been to medical school, so you've seen both sides of the coin. I think you've got a fairly balanced view there, and you obviously work with a variety of people. But what advice would you want to give to people who are not clinicians like yourself, but also want to get involved in global surgery?
The chat with Roba was basically, I thought that was the question that I had as well, right? I mean, I'm doing healthcare system stuff, public health stuff. So what contribution could I make to global surgery? And then, she told me about the Lancet Commission, and there's hundreds of millions of people who don't have access to safe surgery. And, if they have a broken hip or something like this, or a broken bone, then they're not able to work. And obviously there's a lot of suffering that can be caused from lack of access to global surgery. So I know I talked about demand side, supply side, reducing demand where we can. But I think there's also this notion that people who don't have access to safe surgery will suffer. And for people who may not have a background in surgery, might be an economist, might be a public health person, etc. I think the root cause is to view it not as surgery, but as a reduction of suffering. And one means of doing that is by augmenting and strengthening the surgical systems in these countries. And I think as much as possible, trying to prevent the demand, road traffic accidents and electrical burns being one example. But where that's not possible, to augment the systems in whatever capacity. So trying to get more funds to flow to them, or to help them organize their systems better, get them, better technology, etc. So that would be the starting point, is to not see it as a silo of this is just for surgeons, and to see it more from the perspective that if people don't have access to safe surgery who need it, they will suffer, and it could mar them for their entire lives. And then taking a step back and seeing the entire system and seeing, okay, where can my skill set actually contribute to this? Because it's not just about the surgery. They also need technology. They also need resources. They also need training. So is there something that I can contribute? And I can see that it would definitely be a very, very multidisciplinary approach to build global surgery to what it needs to be.
Completely agree. I think that's, frankly, you just hit the nail on the head of exactly what the goal of our podcast is, right? To bring together people like you, people in tech, people doing all these great things around the world that are really important. And global surgery takes an army. It's not just one person. And we're very grateful for people like you who are tackling the issue on so many other fronts. We just wanted to ask you one more question before we go into our final 5. Obviously, you came from a varied background, starting in a PhD and in the medical school, and now you're here. And so what advice would you give yourself looking back, maybe talking to your previous self 10 or 20 years ago? What would you have told yourself?
Ask more questions. That's pretty much it. I mean, I don't know. It's just so completely unpredictable. I mean, as I told you, there was just a bunch of random circumstances that came together. And yeah, I don't want to say that what I've done is perfect, but I'm not dissatisfied with what I've done. And I don't know if I could have achieved more. Not to say again that it's perfect, but it's just maybe if I asked more questions, then I could have made moves that could have helped more people because I would have had a broader perspective. So maybe that's what I would give, the advice I would give to myself. That said, I do ask a lot of questions, and people get annoyed with all the questions that I ask. So, but that's what I would tell myself.
So on that note, we've got a few more questions for you, 5 to be precise. And these 5 questions are dedicated to the 5 billion people worldwide who lack access to safe, affordable surgery. The first question will be something probably very easy for you, and that's, what is the most recent book you've read?
It was a book on the Rochdale pioneers and cooperatives. So they started a cooperative, I think, in 1840-something, and in Rochdale up in northern England. And the reason I'm reading this is thinking about the COVID aftermath and how many people are going to be losing their jobs. I think 30 million have already lost their jobs in the US, and I think worldwide there's going to be even more. So I think this notion of a cooperative might be a means by which we could help people to sustain a livelihood. So that's why I read that book. Very interesting.
Our second question is, obviously I've already talked to us a lot about your background, but what's maybe something that not very many people know about you, or a unique talent that you have?
I can move one eyebrow at a time.
I wish.
Seeing it's a podcast, we don't need to ask you to do that.
So you can't validate it. I don't know if I can actually do it. I could be a fraud.
Wish people could have seen.
Yeah, if only.
Our next question is, what was your favorite toy growing up and why?
I like Transformers. I don't know if this is during the olden days when I was growing up, we had Transformers where you could have a car and then you could like transform it and move pieces around and make it into a person. So I like Transformers a lot.
And maybe a good segue into what you eventually became, right? Of
I suppose
kind of taking things and then changing them and being like, oh yeah, I like that. How about we try it this way? Let's twist this. See what else we can make of that. I mean, and that's great. And that's what we as physicians, also as we as researchers, as tech people, need to be thinking, as you said, outside the box and looking at a problem and seeing how we can deconstruct it, and not just think about it from our lens, but from the lenses of those around us. So I think that's something that I've definitely taken away from today. Our fourth question is not a loaded question, but how would you spend $1 million?
I'd probably, I guess, split it into stocks, bonds, and charity. 3 3 3 3 3 3 3 3 3 for each.
I like that. It's a very balanced approach.
Yeah, very, very practical, which is really good.
And lastly, you've given us a lot of great things to think about, but for yourself, what was the best piece of advice you've ever received?
It's sort of almost an indirect piece of advice in the sense that it wasn't explicitly told to me, but it was implicit in the behavior of the people that I work with, particularly Sir Muir Gray and Sir Ian Chalmers and people like that, Professor Peter Littlejohns, who was the first medical director of NICE, people like John Moxham at King's College London, who I admire very much, which is they're just completely mission-driven. And so, your question, I think, Brianna, that you asked about nascent healthcare systems, what should they focus on? And my comment was looking at the outcomes, having a strategic perspective. And what I saw with these people, and what I admire so much about them, is that they defined the outcome that they wanted to achieve. And then they worked towards it. And they didn't really give themselves a time frame, but they just said, this is what I'm going to do. I want to help people. I want to make sure the patient's voice is heard. I want to make sure that we're using evidence-based medicine. I want to make sure that meet the needs of deprived citizens, those four people, that their respective missions. So I would say that's probably the best implicit advice that I've received, because it's helped to guide myself on my journey in terms of just being mission driven and defining a mission for myself and sort of big, hairy, audacious goal that I want to achieve, and then working towards it slowly but surely.
And if you don't mind me asking, what is the mission that's been driving you?
So I was toying between, this is, going back several years, whether it should be to help people or to reduce suffering. And I settled on reducing suffering.
Thank you so much for sharing all of this information with us. I think I've really learned a lot from what you said. And the things I will really take forward from this are just, making work patient-centric, looking at outcomes, and most importantly, asking questions, which I think are just hugely valuable no matter what you're doing, whether that's in the global surgery field or outside of it. But thank you so much for taking the time to share all that with us today.
Thanks so much for organizing this and hosting it, both Anna and Taylor. Really appreciate it. And best of luck with this great initiative. And, I hope you're able to inspire all sorts of people all over the world.
We appreciate having great minds like yours on the show. So again, very much appreciated.
We hope you enjoyed this episode of Global Scalpels. If you're interested in learning more about this topic or the speaker, visit us on the web at globalscalpels.com or any of our social media platforms. Please subscribe to our podcast on Apple Podcasts, Spotify, Google Play, YouTube, and Stitcher to hear more great content on a wide range of topics within global surgery.
If you or someone you know is doing something in global surgery you feel should be highlighted in Global Scalpels, we would love to hear from you. Thank you again for joining us today and hope to see you on our next episode.